What I welcome you guys to do is type me questions as I go through this, and when I'm done, I'll come back and try and answer as many as I can. We can always communicate further via email if necessary. Before I begin my presentation, I want to just give you a quote from a very famous doctor from over 150 years ago. William Osler was credited as a medical doctor with bringing the practice of medicine from the classroom to the bedside, in essence. And he has some very famous quotes attributed to him. And the one that I think is so necessary and appropriate for CRPS is this one. It's doctors listen to your patients. They're telling you their diagnosis. Problem with CRPS you're going to see is it's a clinical assessment, a proper history that has to be taken. Also, from the surgeon that I trained under, I've been taught for many years, and I've trained myself to always think that all pain can be traced to a source. There's always a trigger. There's always something that's causing the pain. If that's the dominant symptom, it just has to be looked for and accounted for. Okay, so CRPS, what is it? Stands for Complex Regional Pain Syndrome. An older name was RSD, Reflex Sympathetic Dystrophy. They're essentially the same thing. CRPS is a disease of the sympathetic nervous system. That's a branch of the autonomic nervous system. Autonomic means self-regulating. You have no control over it. When this disease hits you, this is not a hyperactive sympathetic nervous system, but rather a dysfunctional sympathetic branch of the autonomic nervous system. Things are not behaving properly. This disease can affect children, it can affect adolescents, it can affect adults. Nobody can be spared if you are susceptible to and develop it. As an overview, we have the sympathetic nervous system and the parasympathetic nervous system. And you might have already heard that term of the fight and flight response. The sympathetic nervous system is responsible for that flight and fight response. That is, that it gets your body ready to either fight or flee. So if somebody, as an example, comes up behind you and says, boo, and they scare you, your eyes open up wide, you take more air into your lungs, your muscles tense up, the body's being made ready to do battle or to get out of there. The opposite is the parasympathetics, and that's to quiet the body down, to rest and digest. So these two systems of the autonomic nervous system, they work in conjunction with each other, but in a nutshell, it's the sympathetic nervous system that becomes dysfunctional when you have CRPS. In a nutshell, the sympathetic nervous system has three main functions. Number one is it regulates your vital signs, that's blood pressure, pulse, and respiration. It also is responsible for maintaining body temperature, and it's also responsible for regulating the immune system and all glandular activities. What you can appreciate is if you look at the innervation of the sympathetic nervous system, all organs, external and internal, get a sympathetic supply. And therefore, all organisms can also be affected by any type of sympathetic dysfunction. So the goal of the sympathetics is to then protect and maintain the internal environment of the body. And when you hear the term CRPS, Complex Regional Pain Syndrome, the term complex does not mean complicated. It really means multifactorial. Complex because so many parts of the body, internal and external, can be involved. And as we go through this, you're going to see that there's almost no rhyme or reason to this disease, but that's the fact that it can affect so many parts of the body at any given time in any given way is what it sort of makes it complex, because sympathetic nerves are found throughout the body, and sympathetic nerves are actually hitchhikers. They're responsive, they travel along the body by being attached to arteries. And as such, any part of the body that gets a blood supply also gets a sympathetic innervation as well. So all parts of the body are going to get a sympathetic supply, as all parts of the body get blood supply. Now, just to distinguish the sympathetic nerves from the sensory nerves of the body, we have what are called sensory or dermatomal nerve type distribution. That is, you have a nerve to an area, a nerve to an area, a nerve to an area that goes down the right side of the body and then also goes down the left side of the body. These sensory nerves is a nerve to an area, left side, nerve to area, right side, and that's nature's design. That's sensory innervation. When you talk about sympathetic nerves, we actually have what are called thermatomes, and there are four of them. Thermatomes, thermal means heat, The sympathetic nervous system is charged with regulating body temperature. And as such, there are 4 thermatomes of the body that it does this by. These are, rather than having a single nerve to an area, there are rather quadrants of the body where the sympathetic nerves are trying to maintain its proper regulation. As a dentist, the one that I'm most concerned with, obviously, is the carotid thermatome, because that's the one that controls anything that happens to the head, neck, face, and mouth. Now, with that said, the big difference between sensory nerves and sympathetic nerve innervation is that the sympathetic nerves talk to each other from head to toe and from left body to right side body. There's a communication between these thermatomes, and that is because the sympathetic chain is like one big long strand that goes from the base of the cervical spine all the way down to the lumbar spine. It comes right back up, and then there are connectors that connect left to right. So when you have symptoms of sympathetic dysfunction, rather than it just being in one area of the body from a nerve to an area, rather the entire body can be affected. And as such, you can have symptoms that go from the head one day to the foot another, that go from the left side of the body to the right side of the body, and there's no rhyme or reason to it. It's just the nature of the way the sympathetics are spread out throughout the body. Okay, so one thing that's very unique about CRPS is that on the McGill pain scale, maybe some of you have heard of it, the McGill pain scale is the #1 most painful disease listed on the McGill pain scale, and yet doctors and the healing arts professions are ignorant of it. They don't know how to diagnose it, and they don't know what to do about it. And as such, people suffer, and they suffer to the point where they can almost lose hope because the pain is so overwhelming. And pain's not the only symptom. It gets the headline, but this pain is so unrelenting and so disproportionate that people lose hope. And unfortunately, some people will ultimately take their life. It's a horrible thing to have happen. It does happen. It's the most painful disease, yet it's misunderstood and it's not properly diagnosed. I'll show you how the proper way to diagnose it is. Okay, so I said pain gets the headline, but this disease has much more to do with it than just pain. Here's a chart with a spread on the signs of complex regional pain syndrome, and you can look at it. It's not just about pain. Every part of the body that gets the blood supply can be affected by CRPS. So if you look at this, you can have pain to the carotid thermatome, which is the head, neck, and face, blood supply issues, internal organs, muscles, bone, everything can be affected. It's a horrible disease. And the fact that these symptoms can go from head to foot and left to right and vary in the way it attacks the body and vary in the way it shows itself, CRPS is also known as the disease with a mind of its own, because it can affect you on any given day, any way it wants. It's the nature of that disease is what can become the tip-off that that's the disease that you have. And it's unfortunate that this disparity in symptoms is what often pushes patients to go to different doctors who only diagnose in their own backyard, so to speak, and then therefore the overall disease gets missed. Okay, so how do you diagnose CRPS and how does it affect you? The best way to understand that, if you haven't heard of this, or if you've heard of it, don't fully understand, or maybe you know it, the way we diagnose CRPS, the standard of care since 2007 is what's known as the Budapest criteria. It was first published in 2007. If you want a copy of the article, you can go to my website and you can download it right from the home page of my website and take it to your doctors. As the 7-pager that was published in 2007. This is a more comprehensive article on the Budapest criteria. It's about 50 pages, the same author. The 2007 version just gives you the nuts and bolts of the Budapest criteria. But here it is in a nutshell. CRPS was, prior to this, was sort of had a moving target type diagnosis. And the reason for that was doctors couldn't agree, on what constitutes CRPS. And when these doctors sat down and they said, let's nail this thing down and create a diagnostic criteria objective, because the most important thing I can tell you tonight about CRPS is that early diagnosis is critical, because treatment is critical, to institute treatment and get in as quick as you can to prevent this thing from spreading. So in a nutshell, there are categories of diagnosing CRPS, and on a history taking, you want to see at least 3 out of the 4 categories on a history you take. And then at the time of presentation, you want at least 2 categories to have signs as well. Okay, so there are 4 categories. Here they are. This is the Budapest criteria. Number 1, you have to maybe have some sort of pain. There's different kinds of pain. This is pain that's disproportionate to any injury you might have had, and that it does not resolve itself. Okay? It doesn't go away. It stays with you. There's different kinds. There's sensory pain, or known as hyperesthesia pain. That's pain to the senses. An obvious one is the skin. People come in, you can't touch them. You can't, they don't like to be touched because it hurts to be touched. They could have eye sensitivity, they could have sound sensitivity. Hyperesthesia is pain or sensitivity to the senses. And it becomes painful to them to have any of the senses stimulated. There's hyperalgesia, that's an exaggerated pain to a painful stimuli. So I can pinch myself and it hurts. To somebody with CRPS, it hurts a lot. And then there's allodynic pain, and that is pain to a non-painful stimulus. So maybe you just touch somebody and that would not bother us, bothers them terribly, it hurts a lot. So there's different kinds of pain that don't line up and don't make sense. Second category, there's vasomotor symptoms. That's temperature dysregulation. These patients come in and they can have one part of the body is red and hot, and another part of the body is white and cold. It could be one side of the face. It can be one hand is red and hot, one hand is white and cold. They have what's called patriotic blanching of the skin. It means like they can be red, white, and blue. It's a circulation problem, because remember, the way these sympathetics affect the body is through vasoconstriction. They travel along arteries, and the effect they carry out is by causing vasoconstriction. They cut blood supply down to an area. That's why your skin turns white when you're out in the cold, because you vasoconstrict. Well, cold is the enemy of CRPS patients, because when you vasoconstrict, it's a sympathetic event. If you have CRPS and you trigger a sympathetic event, you can light yourself up and have a flare just by being out in the cold. Many of you probably already know that. So vasomotor is temperature asymmetry. One part of the body hot, it could be one side of the head. It could be one hand versus the other side. Any part of the body with some sort of temperature dysregulation. You have what's called pseudomotor. Pseudo is fluid. It can be the fluid that you can see and the fluid that you cannot see. There's the visualized and the non-visualized. Visualized could be one nostril leaking fluid, one eye leaking fluid, one ear leaking fluid. People come in with one arm sweats, but the other one doesn't. Things like that. That's pseudomotor, fluid that you can see. Non-visualized, that I see very often, is a pressure sensation to the head, where patients feel like they got a balloon inflating in their head, and it feels like it's a fluid pressure type event to the sinuses, maybe to the ear, one side, both sides, or just the head in general. And tests are negative. They have CAT scans, MRIs, and such. They don't see anything. Well, it's a nerve. It's a sympathetic nerve dysregulation that's causing it, but it is a pseudomotor event. It comes under that category. And the last category is motor and trophic changes. Motor is movement. These patients have times where they're in spasm, where they can't move their jaws, they can't turn their head, they can't open or close their hands, they're stuck closed, they're stuck open, they have vesiculations, perseveration, that means quivering, where for me, it's the jaws are quivering. They can have their hands shaking and quivering, things like that. And the goal, and if you look at these 4 symptoms on a history taking, you're looking to see, have you had any of these symptoms? 3 out of 4. On presentation, that doesn't have to be right then and there. Recently, have you had 2 out of the 4? If you do, you've confirmed CRPS, and now you get it in treat. There's nothing to debate. It's early diagnosis is critical, because the symptoms can spread. The earlier you catch this, the greater the chance you have. Not a cure, because there's really no cure at this point, but there is abatement. And there's a way to abate these symptoms, to give people back quality of life. That's what we're talking about. Okay. Along with those 4 categories, almost always patients have what's called limbic system involvement. Limbic system is the part of the brain that has to do with the emotional center. And the link of CRPS to the limbic system is that the sympathetic nerves terminate in the limbic system part of the brain. And as such, these patients can be very prone to anxiety, depression, poor mental focus. That's the brain fog term you might have heard. They have terrible insomnia. They have personality changes with agitation and such. And Either they're aware of it or significant others are aware of it. The key thing here is that the clinical symptoms are not constant. They can come and go because the symptoms can wax and wane because patients have times of remission and times of relapses. Cold is a trigger, stress can be a trigger. People come in, they've had some stressful event in their life, that becomes a trigger, and you got to go in and treat. Okay, and the bottom line is, though, the more diverse the symptoms, you have to say to yourself, is it possible that somebody has 10 different things wrong with them, or maybe one disease that blankets everything? That's what you're looking to try and figure out. And if you think in terms of how different the symptoms are and no test is confirming anything, because you want to get blood tests and different imaging to make sure that there's nothing else going on, you can certainly have more than one thing, comorbidities. But when you don't have tests that line all these things up, you start thinking in terms of sympathetics. What causes it? There's usually a trauma-based event. The sympathetics get triggered, and every time you get cut, every time you get stressed, I ask patients all the time, have you had any injuries or traumas in your lifetime? That could be sports related. It's not always a car accident. I ask patients if they've had surgeries, because every surgery, every general anesthesia, every sedation, the sympathetics are going to respond, because that's what's designed to keep the body functioning, even in the face of a properly done procedure. Those are traumas. Okay, so patients say, well, I haven't had any traumas. Have you had surgery? Yeah, I've had my appendix out, my gallbladder. And they start rattling off all the surgeries. Well, those are traumas to the body. And those can potentially be enough to cause the sympathetics to become dysfunctional, and therefore they begin to react in a dysfunctional manner. So there is what's called a threshold event. Usually 3 traumas can be a trigger, but you can get CRPS if you're going to be prone to it from nothing. You can just develop it. It just becomes sort of a bad luck event. But usually there's going to be some sort of trauma in some manner. It doesn't have to be something that you remember or witness, but rather things that just occur. Okay, so you always want to take a proper medical history, a proper trauma history, and for me, it's a dental history. When I ask about surgeries, I'm interested because if they've had general anesthesia for basic operations like appendix and such, the neck gets hyperextended and the jaw joints get hyperextended, and that can be a way of triggering injury to the jaw joints and/or cervical spine. I'm going to show you that those can be triggers for a CRPS-like event to begin in a patient. So you always want to have a proper history. It's just a matter of asking questions. Okay, so when all these other tests come back that are negative and patients come in, I had all these tests, blood tests, imaging, nobody can find out what's wrong with me, yet they have all these different types of symptoms, motor, vasomotor, dystonias, and disproportionate non-resolving pain. That's the tip. If you get that Budapest criteria in your head, you can then become very easy to diagnose sympathetic dysfunction and then begin to treat. When no one mechanism can explain what's going on with these patients, you think sympathetic dysregulation, you think CRPS. Okay, the game here again is the earlier you diagnose it, the better the chance you have to contain it, properly treated. For me, I have these questionnaires that I send out to patients. They fill these out before they come in, and they're full body. You can see one for muscle tightness. These patients, it's amazing when they fill these forms out. If you look at the thermotomal diagram, there's the carotid and brachial and mesenteric and femoral. Look at how these patients diagram their symptoms. These forms almost diagnose the patients with CRPS, because these symptoms of muscle tightness and numbness and body pain questionnaire and skin alterations and swelling and such, these are the symptoms you get with sympathetic dysregulation. And it's amazing to me how they map out these symptoms. This is a giveaway. It always makes it obvious that there's some sort of sympathetic dysregulation going on here. So these patients fill out these forms in advance, so I have a chance to study them. And all of the paperwork they do fill out, trauma questionnaires and such, all go into a template so I can sit and review all these things with them. These forms become very helpful. I also have a CRPS screening form, and you can see signs and symptoms on history and on presentation. And here's the Budapest criteria laid out with some more specific questions for me to ask them as I try to hone in on certain things. But this makes it very easy to confirm the diagnosis and then start to explain it to the patient. Okay, in a nutshell, real quick, why is this significant to dentistry? People say, you're a dentist, what are you doing with patients who have symptoms to their feet and to their torso and maybe internal organ symptoms? Okay, well, these patients have problems that you see this list of what can happen, and here's what happens. I'm interested in the carotid dermatome, but remember, the symptoms to the carotid dermatome, the head, can spread beyond there. So I want dentists to know that there are all kinds of symptoms that patients can have that they can present when it comes to the dentist. They have patients, you can't get them numb, their bites aren't right. They have spasm in their jaws. They have new pain from a basic dental procedure like hygiene. They get their teeth cleaned and all of a sudden they're lit up. Their hand swells up because they had their cleaning done. They get spasms in their back from having a procedure done. They react to foreign bodies like dental implants and root canals because those are foreign bodies, the materials used. Patients with CRPS don't do well at all with any foreign body placement because it triggers the immune system. The immune system is dysfunctional because the sympathetics are governing the immune system, and it becomes a dysfunctional response. I've had people come in with their faces are swollen from an implant. There's no infection, nothing done wrong, but they got CRPS, they got missed. Their gums can be fire engine red and their teeth are killing them. And you don't see anything more gently, but I come in and I'll do sympathetic blocks to the mouth and I can shut this off. So as a dentist, I try to educate dentists on how to recognize CRPS just by saying, listen, you got a patient who's coming in, you think they're crazy. They're not. They're showing signs of sympathetic dysfunction. Okay, remember, CRPS can spread. So I make my patients aware. I try to make other doctors aware, whoever will listen. Okay, just in briefly, because some of you might have experienced this, complications from having CRPS done as a dentist, you can cause the CRPS to spread. If you ignore what's going on with these patients, maybe the CRPS is not in the carotid thermal cone, maybe it's other parts of the body. So the doctor performs a procedure and all of a sudden now they start to show a worsening of other symptoms, still away from the head, neck, face, and mouth, but all of a sudden they say, hey, ever since you did that cleaning, ever since you did that filling, the crown, whatever you had done dentally, I'm getting these other problems, and that's got nothing to do with me. Yeah, it does, because they missed the potential for CRPS. Maybe they weren't diagnosed, but they don't understand that there's a sympathetic relationship that's going on here. So patients can get into trouble from dental procedures, or the doctors have problems with the dental procedures being done. Again, the bite never feels right. Implants, surgeries fail, root canals fail, they don't heal well from extractions. Remember, CRPS is a blood flow issue. If you've got active CRPS, you constrict blood vessels because that's the nature of the disease. And you place an implant, that's surgery. If you do perio gum surgery, the gums are being cut, things have to clot, you got to bleed the clot. And if you've got a blood flow issue, they're not going to heal well. So they have all kinds of post-op problems when that gets missed. So I tell patients, you don't want to do certain types of dental procedures. It's going to be hard to get them numb. The trigeminal nerve normal innervation is overridden by the sympathetics. And these patients, they can't even hold their mouths open. There is a way to treat them, but they have all kinds of dental problems. Even braces, orthodontics is contraindicated with a patient who has active CRPS. You've got to get these patients under control. And I try to teach dentists that, and I try to tell doctors that. And there's a way to do it. But the thing to understand is that it's not that you should be afraid to go to the dentist if you've got CRPS. If you're listening in, it's that your sympathetics either has to be brought under control, the dysfunction, or block the sympathetics when you're having the dental work done. That's what I do with nerve blocks that I'll talk about a little bit later. Okay, so the question, well, how do you sort all this information out and decide what to do? The easiest way to understand that is that you have to diagnose before you treat. And the reason for that is this: if you diagnose before you treat, the patient owns the problem. If I tell you, here's what's going on, and here's the risk factors and such, you make an informed decision, not only about treatment, but understand that if anything happens, here's the reason it's happening. Unfortunately, a lot of what gets done is that doctors will treat something before they fully know what they're dealing with, and now the doctor can get blamed, and or maybe rightly so, they made a problem worse because they missed what was going on. Because doctors tend to stay in their own backyards. CRPS, if you understand that Budapest criteria, can haunt you in so many different ways. So again, I try to make doctors and patients aware of that. Yeah, so the question, what can I do as a dentist? How do I help this type of population? And if a patient comes to me, usually being referred for something atypical, if they satisfy Budapest criteria, and I have this adage in my head that all pain can be traced to its source, I'm going to look first for mechanical triggers that are potentially feeding sensory pain into the central nervous system, causing or sustaining the CRPS. Because here's how it works. When somebody has pain, you get sensory pain that goes into the brain. The brain kicks out a sympathetic response. that sympathetic response is dysfunctional, and then that continues to kick pain back into the brain. And what happens is you set yourself up for this self-sustaining wind-up mechanism of pain into the brain, sympathetic response out, dysfunctional response, more pain. And that's how triggers that don't get identified can keep people lit up with CRPS. So for me, at least, what I'm looking for are my two main triggers. That's jaw joint and cervical spine. Now, you might be thinking to yourself, well, wait a minute, what does a dentist need to know about cervical spine? Why should anybody potentially concern themselves with cervical spine issues with respect to CRPS? We're talking about CRPS. Here's the answer. Okay, this is really the classic textbook written, published, copyrighted back in 1992, almost 30 years ago, by Dr. Hushman. Dr. Hushman was a brilliant expert in CRPS, dual degree, psychiatry and neurology. And this is his classic book that I've read front to back. Number one of his statements in his book is that cervical spine pathology, this is why I concern myself with the cervical spine. Cervical spine pathology. Cervical spine, if you don't know, is from the base of your skull to the top of your shoulders. That's your cervical spine. Cervical spine pathology causes sympathetic dysfunction. If you have a problem with your neck, you can develop sympathetic dysfunction. An old term for that was called Barry-Lou. Barry and Lou were two separate neurologists back in the 1920s. They each described the same symptoms of sympathetic dysregulation. The third doctor came along, saw the same thing, gave them credit for the name. Historically, that was one of the older names for CRPS. So that's where Barry-Lou comes from. Basically, that basically gets CRPS. So cervical spine pathology can cause dysfunction. So if you've had operations where your neck's been hyperextended, maybe you've had a car accident, maybe you've been bumped, you played sports, whatever it is, if your upper cervical spine has been knocked out of alignment, that can be a trigger for sympathetic dysfunction. That could be a mechanical trigger, that's keeping you lit up, and it needs to be investigated and treated if necessary. Number two, cervical spine pathology is quite frequently accompanied by CRPS. So if patients come in, confirm Budapest criteria, confirm with CRPS, I'm automatically got to look at their neck. And the way to do that is just with a basic MRI. You can do it with CT as well, but you need to evaluate C1 to C3 mainly, because that's the area that refers also to the head, neck, and face. And this is the main reason, perhaps, that I have to be able to look at the cervical spine. Trauma to the cervical spine results in referred pain in the distribution of the trigeminal nerve. Okay, what that means is that you could have no problem with your jaw joints, no problem with any innervation of the trigeminal nerve. So that's the upper jaw, the lower jaw, the gums, the teeth of upper and lower jaw, and the TMJs themselves, the temporal mandibular joints. Yet you feel like you do, okay? And it's coming from your neck. And that can be coming from as a sensory pain referred or a sympathetic referred pain. So we always want to get MRI of the TMJs and the cervical spine. And I've been trained to do my own reads, because if the joints are normal, but they're showing signs of trigeminal nerve type problem, I'm going to look at the neck and see if there's a contribution. Then I'm going to start to isolate with nerve blocks and things that I do, but I'm looking for triggers, mechanical triggers. And the most obvious one, if the joints have a problem and that's a source of pain, that's not going to trigger the CRPS. It's going to put pain into the brain as a sensory input, and it's going to send out the sympathetic response. And again, if the sympathetics get overwhelmed, you set yourself up for a potential sustaining sympathetic event. If the cervical spine is damaged or injured, that by itself can be a reason, A, to have referred pain mimicking fifth cranial nerve issues, and or it can be a main trigger for CRPS RSD. Okay, and this is a direct quote from Dr. Hushman from 30 years ago. Unfortunately, the role of cervical spine pathology in RSD has been recognized by a few clinicians, and that's probably still true today. It's unfortunate, but I think it's true as well from what I see every day. Okay, look at this website that I just put up. It's rsdrx.com. If you have a chance, write it down. This is the Hushman website. He passed away a couple of years ago, but this is still kept active by his research assistant. And as such, there's a tremendous amount of articles on CRPS on this site, and he has this hundreds of what are called Q&As that were sent into him over the years from patients from all around the country maybe even the world. I've looked at them all. They're basic questions of problems that patients had with CRPS that he gives you very basic answers to. Tremendous information on this site, rsdrx.com. I highly recommend you, when you have a chance, to spend some time on that site. And here's a little more recent. This is from a chapter from a textbook that Dr. Piper, again, he's the surgeon that I trained under, and he's talking about the cervical spine. This is a CAT scan-like image. This is the C1. This is the highest level of the vertebra. This is the patient's skull base. Then here's the quote that I want you to see. When the C1 has been deviated, you can get pain that radiates to the skull, lateral face, the side of your head, your forehead, and the retroorbital region, which is behind your eyes. A C1 malalignment and the associated pain that comes with it can mimic a TMJ-like problem when there's nothing wrong with the joints. So a lot of patients, besides the CRPS, they're getting mouth guards made, muscle relaxants, anti-inflammatories. They're going through all kinds of things. A lot of time, a lot of money gets wasted, and the problem is actually coming from the cervical spine. So you always want to look at neck. Okay, so you always want to look at neck and jaw joint together. And here are some images from a recent patient. You can just see how the spine is curved here. It's just showing you there's a problem. And the jaw joints might have some damage, minimal damage, a lot of damage. All those things have to be looked at and accounted for. And here's the bottom line. When you go to your doctors, if they offer you a treatment and that treatment's not working, you have to say to yourself and say to them, either the diagnosis that you come up with is wrong or the treatment is wrong, so you rethink it. So that's why you spend a lot of time upfront diagnosing. For me, it's that those forms that patients fill out, proper clinical assessment, imaging of neck and TMJs and such, and then think it out. And then I start to begin to do diagnostic treatment and such, but you can oftentimes figure things out with a proper assessment. But what you don't want to do is just go and start treating without a full proper diagnosis, because if you're not getting results, ultimately it's the patient that's going to suffer. And you have to realize if it's not working, something's being missed. How do you treat the CRPS patient? First thing we have to do is identify and then eliminate or control all mechanical triggers. And then when we talk about the next topic, the gadolinium, is also a chemical trigger. And here's the key thing. Treatment must be multifactorial and it must be simultaneous. The mistake that gets made when I show you these things is patients come in, they're on all kinds of medicines, but it might work a little bit, maybe not at all, but it's not enough. Or they come in and they're on anti-inflammatories, or they're just on muscle relaxants, or they're getting PT, or maybe they've had some injections. The problem is they're getting them done individually and not at the same time. CRPS is like a mad, vicious dog that's loose in the backyard, and the way you control it is by getting as many leashes on it as you can. And all those leashes have to be there at the same time. That's how you control this type of an event. So my first line of attack to diagnose is what are called diagnostic/therapeutic peripheral nerve blocks. I know people have come in and said they've had epidurals and paravertebrals that are close to the spinal cord. The blocks that I do right in the dental chair, if you think in terms of the spinal cord like a tree trunk, and then the tree trunk gives off a branch to a branch to a branch, and you've got these branches that are 5 and 6 branches away from the tree trunk. Okay, so spinal cord is the tree trunk. And now you have branches of nerve to branches of nerves, and it goes further and further away. That's where these peripheral blocks, peripheral means away from center. And these blocks are these nerves that I go after, they're loaded with sympathetic nerves that innervate the carotid dermatome. So I can isolate sympathetic innervation from the neck to the face. If somebody comes in with all kinds of so-called trigeminal nerve or TMJ-like problems, but I don't see a reason for it, I'll block the sympathetics and see what kind of response I get. And I get that response within minutes in the chair. A, it becomes diagnostic. B, it becomes therapeutic, because if you get it early, these blocks are a form of treatment. It gets people comfortable, and that comfort becomes sustainable. Okay, sometimes we have to use medications to regulate nerve function. Lyrica is my favorite. People have Neurontin. There are others. What's good about Lyrica is that you can get in there with a low dose. It's rapidly absorbed, and within a few days, you can get an effect if the patient can take it and tolerate it. I don't use it that often, to tell you the truth, but it's a medication that people get on. The problem is they get loaded up on a mega high dose, and they get terrible side effects because they're on too high of a dose, perhaps, but they're also not doing other things that should be done, mainly looking for what the mechanical triggers might be and such. So we always come in at lowest therapeutic dose. You start subclinical, and then you work your way up. And for me, I've really never gone beyond 75 milligrams per day, 25 milligrams 3 times a day. That's right around usually what's enough in conjunction with blocks. It depends on how they respond to the blocks, dictating what I would do next. And let me tell you, these blocks, remember, the thermatomes are connected. So it's amazing that patients come in with terrible pain to the mouth, to the face, and to the teeth and the gums and such. And I block these, but they also have other symptoms to the other thermatomes. It could be their hands are tight. There could be some swelling and such, or they could have spasms in the upper back that are not normal, responding to what you think heat and massage and such. And you block the sympathetics up high, and they actually get relief to the other thermatomes, sometimes all the way down to the toes. It's quite remarkable to see just a few minutes in the chair and it hits. So the more we catch, I'm glad, but I'm going after what's related to what they're coming to me for, which is to the carotid thermatomes. But it's amazing. These are simple to do and learn blocks. I can teach anybody who's licensed to inject can do these shots. That's nurses, doctors, dentists, I believe PAs can inject. Anybody who can give you a shot can learn these things. They're great for diagnosing and quick treatment. Okay, we use muscle relaxants, Klonopin, clonazepam if necessary. Again, lowest dose. What's good about Klonopin is it works on the limbic system. Remember I said the limbic system is where the sympathetics terminate. So we always want to use medications that will reach the limbic system, as but one example. We want to get things that hit the areas where the sympathetics are going to create their problems. Anti-inflammatories. Study done in 2014. There were the 3 top non-steroidal anti-inflammatories, NSAIDs, that cross the blood-brain barrier. The blood-brain barrier is like a screen that protects the brain from chemical invasion, but there are medications that are able to cross it. And the way it does that is through introduction into the body, crosses the blood-brain barrier, and that can affect its effect on the body. And the best NSAID for me that I use all the time is ibuprofen. You can call it Motrin, you can call it Advil, whatever you want. 400 to 600 milligrams 3 times a day helps to bring down inflammation. It crosses blood-brain barrier. That's a good medication. You have easy access to it. If a patient can't take it, okay. Not everybody can take the meds that we try to use. That's okay. I haven't really met anybody that couldn't tolerate the blocks. I might not always get the profound effect when I get some effect, sometimes no effect, but usually I'm going to get some result. My experience has been diagnostic nerve blocks in conjunction with NSAIDs like the Advil and such is more than enough to get these patients under control if you're getting them early and it hasn't been significant spread. The more they've had it, the more aberrant care and treatment, the more the spread, the deeper the problem that you have. Physical therapy, massage is critical because once you get CRPS, it becomes, patients become more non-ambulatory. They don't want to use the limb because it hurts, or their fingers or their feet. And the more you don't use a part of your body that's got CRPS, the more you vasoconstrict. The more you vasoconstrict, the more you lose blood supply. So the goal with these nerve blocks is not only to get relief, but also you're going to get dilatation of blood vessels. So you're going to get blood flow back into an area. And that's where PT and massage comes in, because the PT and massage is what starts to get all these byproducts of metabolism out of there. That's your lactic acid, carbon dioxide buildup, substance P. It's all the things that you want to get out that's getting stored and stuck in muscles and body tissue that's causing problems. So when you do these blocks, you go do it in conjunction with mechanical movement. And in my office, I have a PT chair. I have that big PT chair. They go in there and it just works their whole body after the blocks, and they get good relaxation. And they feel better. It works quite well. Okay, so it's critical. And also over here, no pain is gain. You know, the old adage, no pain, no gain. That was from the gym from a long time ago. You never want to introduce pain to a CRPS patient, because if you make them hurt, you know, there's no such thing. Push a little harder, do an extra rep, and you know, that kind of nonsense. Because if you introduce pain, you're going to introduce a sensory input into the brain, and then that's going to potentially lead to a sympathetic response out. So it's always sub-pain treatment. And when I recommend PT massage and such, whoever they go to knows that, no pain induced. Finally, we have the CRPS diet. Maybe some of you have heard of this. The idea is to eliminate foods that stimulate the sympathetics. And this is from Hushman himself. Basically, again, this is published a long time ago. You don't have to read this thing. It's just to know that there are foods that stimulate the sympathetics by stimulating the secretion of the neurotransmitters that feed the sympathetics. And if you're interested, you can go to my website again. You can download this. If you look at this, there are foods to be avoided. We call it the 5 C's. There's cookies, cake, chocolate, cocktails, and candy. It's all the stuff we like, but these are all the things that can keep the sympathetics lit up. And people get upset when they see no coffee. And it's not the coffee that causes the problem. It's not the caffeine. It's the acid content of the coffee that can cause a problem. There is non-acidic coffee. So if you really got to have coffee, you can, in fact, still have your coffee. But the foods that are allowed come under the heading of the 4 F's: fresh fish, fresh fowl, fresh fruit, and fresh vegetables. You want foods that are going to have a calming effect on the body, not foods that secrete or tend to cause the secretion of epinephrine and norepinephrine that are going to feed the sympathetics. And this is not forever. It's just another leash on the dog to try and get patients to get these problems under control. So again, here's the thing on coffee. Again, you can download this from the website and read it on your own. It makes sense when you understand it. As I thought I'd do, let me just drop out here briefly. And I just wanted to see if any questions. I don't see any. Does anybody have any questions for me?
I have one, or I have a couple actually.
Okay.
Can you hear me? Can you hear me?
Yeah. Go ahead, Alice.
Okay. So is the peripheral nerve block the same as the stellate ganglion block?
The stellate ganglion is the central part of this of the central nervous system. That's like blocking the hub.
Right.
What the peripheral blocks do is, and again, it's like the nerve to a nerve to a nerve. So I'm blocking a peripheral branch that's way away from the spinal cord. It's a branch, I guess you could say, of the hub, but it's not the hub. I'm nowhere near that. These are minimal risk injections to cause any harm, but have maximum benefit because I'm catching a peripheral branch. You see.
So are you? It does. Are you for this? Like I had my first stellate ganglion block today. Are you for the stellate ganglions, or are you against them?
I'm not for or against them. You just got to be careful because when you get a stellate, if you damaged the stellate with a nerve block, if you touch it with the needle, you can damage it. And stellates can only be done on one side or the other. You can't block both stellates at the same time.
Right.
So, and you can only do that, and you can only do that a couple of times. So what I would tell you is that they have their place. But for me, I can do my blocks every day. I can repeat them. I've done that many times. And what I'll do is have the patient come in. If I get a good effect from the first block, I will then go in and repeat those blocks. I'll repeat them several days in a row as long as I keep getting a positive effect, get them on the anti-inflammatories, get PT on board and monitor their symptoms. It depends on what they come in with. How well do they respond to the blocks? That's the beauty of what I do. I do them right in the chair. They're minimal risk because they're subcutaneous. Can you see me on the image right now? Can you guys see me?
Mm-hmm.
Okay.
Well, you're small. You're really small right now.
Oh, okay. Well, when I come back to the screen, I'll show you. But it's basically a subcutaneous injection. It's done under the skin and over the muscle in the lateral part of your neck, in the sternocleidomastoid area. You're nowhere near the spinal cord. These are peripheral branches. And as such, there's minimal risk to any damage. Really, the worst thing that happens is you don't get any effect from it. That's really it.
What do you inject?
Oh, just local anesthetic. Just a local anesthetic to block the transmission of the sympathetics. These nerves that I'm going after are branches of what's called the superficial cervical plexus. It comes out of C2, C3, comes around and gives off 4 branches. The greater auricular nerve is the one that I go after that it really innervates the whole side of your face and mouth. And there's a transverse cervical that catches the area under the tongue in the front of the lower jaw and the lower front teeth. There's a lesser occipital that goes up the back of the head, and there's a supraclavicular that goes towards the collarbone. So I can block any one of those depending on where patients have symptoms and see what happens. It's amazing when you do them because they get relief within minutes if it's a sympathetic maintained event. And the beauty is I can repeat it because patients will say, yeah, I got relief, and now I'll speak to them. The next day they got more relief, and the next day they got, you block them again and they get more relief, hopefully, and then now you're starting to bring in your anti-inflammatories and hopefully slowly bring this thing under control while still looking for triggers, because something's always keeping these patients lit up. So they're minimal risk, but a stellate, you're going into the hub. When you block a stellate, you're going into the core, and those can only be done so many times, because if you damage a stellate, you're going to damage your whole sympathetic nervous system, because that's the hub, that's the home port. Okay.
Right.
So be careful. That's okay. Did it help you, the block?
I feel like it's helped a little. I'm close to 2 years already in, so he wished I had found him.
Yeah.
Earlier on. So.
Right. So just understand the stellates, you can only do them one side or the other. You can't do both sides, and you got to be careful how many times you do that. And it also depends on what he's trying to reach. My adage is that when I've got main symptoms to the carotid dermatome predominant, meaning to the head, neck, face, and mouth, the teeth, the gums, the muscles of jaw movement, the head, neck, posturing muscles and such, and I block these sympathetics, it's amazing. Within 5 to 7 minutes that they literally start to get relief. The neck loosens up, the jaw loosens up, the pain in the mouth goes down. And it's amazing to see how it hits the the brachial dermatome as well, where all of a sudden they start to get relief in their shoulders and their arms, their hands, their fingers, and even down to their back from a simple injection, subcutaneous under the skin and over the muscle. These are little nerves that are just sitting on top of the side of your neck muscle and under the skin. So they're very easy to get to. Just a local anesthetic. I'm basically with these blocks just telling the sympathetics, take a break. You get a timeout, so to speak. And then let the body see if it can reset itself. It's almost like when you boot your computer. It's not working properly, so they always tell you when in doubt, boot. So these nerve blocks are like booting. And it's amazing how patients respond. And then how long the block lasts for tells me, does the relief they get last for the length of the anesthetic? Does it last for a day, a week, a month? And that tells me what else is going on, but I'm always going to be looking for triggers and such. Okay?
Right. Okay. Thank you.
Anything else? Okay, my pleasure. Anybody else have a question?
Hi, Dr. Gittleson.
Oh, Kyra, I see you. How are you?
Hi, how are you? Sorry?
I'm good. How are you feeling?
I took the Advil. I actually just had jaw surgery, everyone, so I have a splint on. And I was having a really bad CRPS flare. I called Dr. Gittleson in a panic, and he prescribed the Advil and the prednisone, and it took it down like 80% within 15 minutes.
Wonderful. Yeah. I'm glad it helped you. All right. So hang on, because what we're going to talk about next, Kyra, is what you're going to be heading for next week. Let me go ahead and get back onto this screen here. Okay, so let's continue. I want to talk about gadolinium toxicity now, gadolinium deposition disease. Some of you might have heard of it. We'll talk about it. What is it and what's the link to CRPS? And again, I bring you this quote from Dr. Osler. Doctors listen to your patients. They are telling you their diagnosis. And I also have my other quote from Dr. Piper that all pain can be traced to its source. So gadolinium deposition disease. You know what? Let me just keep going here. We'll catch this. If you have questions, you'll have them for me when we're done. So first, what is it? What are the symptoms? What causes it? How do you diagnose it? How do you treat it? Abatement, relationship to CRPS. We're going to talk about all of these things. First, what is gadolinium? It's a rare earth element with a +3 valence. That's basic chemistry. It's known as a lanthanide, known as a bone seeker. It tends to deposit in bone. It competes with calcium, and it's a metal that has a strong paramagnetic property. Gadolinium is used as a contrast agent. Contrast agents known as GPCAs, gadolinium-based contrast agents, are used to enhance visualization of all parts of your body anatomy when getting MRIs and CTs. The MRI procedure is done, and right before it, you get an IV of this gadolinium, and it causes organs of the body to show up better. You create a contrast. Excuse me. Bottom line with gadolinium is that it has no known biologic use in the body, and free gadolinium is toxic to the body. It was first introduced in 1988. There have been over 200 million doses worldwide, and historically, it was considered safe in patients with normal renal function. We now know that's not true. They used to think you just completely excrete it in 24 to 48 hours and causing no harm. This is incorrect. This is not true. And anybody that tells you different is uninformed. This is a dangerous chemical that's used to diagnose and try to diagnose medical conditions. But what we're now seeing and know for sure that this is a bad heavy metal to have in your body if you're susceptible to this disease. So here's a little history. 1991, Routledge noted that gadolinium is in fact retained in the body. Historically, they told you if you have a GBCA injection that you'll just excrete it within 24 to 48 hours, no problem. This is your classic article, 2004. Gibby described retained gadolinium in the body of patients with normal renal function. They used to tell you the only people that can be affected by gadolinium are people who have compromised renal function. And what Gibby showed is that not only, what he sought to show is that gadolinium is in fact retained in patients who have normal renal function. So now we have a problem dating back to 2004, that's 17 years ago. 2014, Conda et al., gadolinium retained in brain tissue in patients with normal renal function. So now we not only know it's being retained in the body, it's also retained in the brain. 2015, the first FDA warning came about regarding GBCAs to use them with caution. Of course, they're starting to see problems come about. Now, let me give you his name, Dr. Semelka. He is the expert, world-renowned, but home based in Chapel Hill, North Carolina. 2015, he first, with his research team, started to describe what's first called gadolinium storage condition. That is that we know if you get a contrast agent injected into the body like gadolinium, it does not just get excreted, you store it. If you get it, you're going to store some. Okay, and the storage is basically mostly in bone and skin, that's 40% and 40%. Then it stores in liver, spleen, and brain as well, and it can be slow released into the bloodstream, leading to what's called GDD, gadolinium deposition disease. And you see it says in a susceptible person. Okay, so what that means is that not just like CRPS, not everybody who gets hurt or injured gets CRPS. Every football player should have it otherwise. Well, not everybody who gets exposed to gadolinium gets sick with it as well. You have to have some predisposition to it, whether it's the immune system or something else that's letting the body be taken hold of by this gadolinium. Okay, the most severe symptoms are in skin and bone. That's because that's the main place that it gets stored. GDD, gadolinium deposition, can occur secondary to physiologic changes when you hit puberty, if you're pregnant. If you have major traumas, the body starts to secretes bone, secretes chemicals, and all of a sudden, where gadolinium is being stored, can all of a sudden get into the bloodstream, and if it does, it can then therefore cause this disease process if you're going to be susceptible to it. Okay, again, this is from all of the work of Dr. Semelka. I give him all the credit in the world. He named this disease, and it's his research that's ongoing to not only to diagnose it, but to treat it and hopefully affect cures and prevention down in the future. So what are the symptoms of gadolinium deposition disease? And the easiest way to understand it is to think in terms of other heavy metal toxicities. One of them is lead. We all have heard of lead poisoning. If you're old enough, you remember the old commercials where children would eat the lead paint off the walls and they would get different types of problems, neurological deficit and such, based on consuming lead from the paint. So here's what happens. Here are those symptoms. I'm going to show you comparison charts and such. So post GBCA injection, whether immediate on the table or delayed. A delay could be within a couple of hours, days, weeks, or months. Patients develop what are called A symptoms. A symptoms are distinctive to GDD and any type of heavy metal toxicity. And here they are, these patients, when you get this type of disease, whether it's a heavy metal, but also distinctive for gadolinium, is brain fog, brain confusion, can't concentrate, can't focus, things like that. They get terrible head pain, dry eyes, muscle spasming. They get pins and needles type sensations, electric shocks throughout the body. They get terrible bone boring pain. They get hallmarkers, burning skin pain. You feel like your skin's on fire. And the way it shows itself is usually peripheral, meaning hands and feet. Dr. Smolka calls that glove and sock. And it's a terrible, terrible, painful condition premeditated by the injection of the GPCA into the body if you're susceptible. And you can get skin discoloration, skin alterations and such, but the hallmark is this brain fog and these burning skin type sensations, terrible, shocking, deep bone pain. Okay, now this is a disease. This is not anecdotal. It's not an opinion. It's not hearsay. This is documented proof from the work of Smolka et al. That this is a definable, measurable, verifiable disease. And I'll show you how that's done. But a disease, by definition, is defined as a morbid condition, a disease, an illness condition with defined symptoms. This is a disease, not a syndrome. It's a disease. Along with these A symptoms, patients oftentimes have what are called B symptoms. And the B symptoms are commonly observed, but can also be seen in other medical conditions. So these are not unique to GDD, but you can also see patients have heart issues. Patients have stomach issues that can be nausea, vomiting, they're constipated, or they got diarrhea, ringing in the ear. These are all signs of inflammatory issues. Neurologic deficit, mood alterations, hair loss, tooth loss, usually because they get dry mouth and such, because saliva flow can be affected. So if you look at all these symptoms combined, look at how sick these people can get because of an injection of a chemical that in essence is toxic to the body. And it still appears from my conversations with radiologists and radiology department heads that they don't know this. The information has been published in radiology journals, neuroradiology journals from the work of Smolka et al. And it's amazing that the ignorance is it's only in patients with compromised kidney function. There's only one type of disease. That's not true. If you've got these type of symptoms, and I'm going to show you the comparison to CRPS, you've got to think, is this CRPS or is it GDD, and or maybe both, and or maybe one causing the other? That's what you got to think of. This is potentially a chemical trigger that I'm going to show you. So if you see these types of symptoms and you've had even just one gadolinium-based contrast study, you potentially might have this GDD type event. And what I added to my medical history forms is a simple question based on everything I've come to know about this. Have you had any MRIs or CAT scans in your lifetime that involve contrast or without contrast, and how many? Because if I suspect, get a positive for that, and they're showing symptoms of CRPS, I'm also thinking that there's an overlap to the GDD. So this is a GDD screening form from one of Dr. Smolka's articles that with his permission I use. And it's basically asking, at the time of injection of GPCA, did you get any symptoms? Up to 3 months, did you get any symptoms? Post 3 months, did you get any symptoms? And here's what we're looking for. We're looking for these symptoms of gadolinium toxicity. So it becomes another way to look for a disease entity, which is a heavy metal toxicity. Okay, so listen to this. The symptoms of GDD mimic the symptoms of lead poisoning. Here's your symptoms. Here's your B symptoms. Here's a chart of lead poisoning. I put this up here because I try to make an impact on people. And this reminds me of the movie Jaws, where you heard them talking on the beach. And the mayor said, if you yell shark, everybody's going to run out of the water and they're going to ruin their day. If you yell barracuda, nobody really cares. Okay, so if I tell a patient or a doctor, this is potentially gadolinium toxicity, they look at me like it's the barracuda. They don't care. But if I tell them it looks like lead poisoning, that gets their ears up because everybody knows about lead poisoning, but people just don't know about this yet. They should, because it's been out there for at least 6 years. That's the medical arena that I'm talking about. And eventually they'll be brought around. But here's the thing, look at the symptoms of lead poisoning from this chart. Look at the A symptoms. Look at the overlap. Okay, this is showing you that a heavy metal poisoning creates these types of symptoms. Okay, and they have the A symptoms. They can also have the B symptoms because it's a heavy metal toxic event. There's an effect on the body that I'm going to show you what gadolinium does. Okay, but how does this relate to CRPS? That's the next question. So if you think in terms of that Budapest criteria with the 4 categories I told you about, here's your GBCA symptoms. Here's a body chart on CRPS. Okay, so now look at these A symptoms, look at the chart on CRPS, and look at the overlap. Look at the symptom overlap. Here you have a chemical invasion of the body that's causing distortion, and yet you have a disease entity of CRPS, which is really a disease of the sympathetic nervous system. So the question is, well, how do these two tie together? How does a chemical toxicity relate to a sympathetic nervous system dysfunction type disease? What's the relationship? You're either dealing with 2 diseases that cause similar symptoms, or you might be dealing with a disease that's causing the CRPS. That is a distinct possibility. Or you might be looking at a way of patients with CRPS that can't be reached, where they're suffering terribly, where it can't oftentimes get the relief that they want. This is potentially what's called a central sensitization treatment. Patients are told, your CRPS is central sensitized, it's been too long, we can't help you. Well, how about if you ask those patients if you've had any image contrast studies done? Because I've yet to have a patient come in who had CRPS before they get to me that didn't have at least 1 GBCA. Then automatically, besides filling out the forms, we're going to get certain studies done to see A, what their levels are, and then B, recommend at least potential treatment to see if they show positive for GDD. I'll show you how that's done. Okay, so to me, gadolinium deposition disease, as somebody who treats CRPS every day, this can be its own disease, or it can be a chemical trigger for the CRPS. Okay, so when I'm treating CRPS patients, I'm always thinking I'm going after triggers. I told you about the mechanical ones, that cervical spine, jaw joint potential for sensory pain in, but high cervical spine as its own trigger of RSD, CRPS. And then here's a potential other trigger. And this new trigger is something that has to be accounted for. And here's the link. The sympathetics govern the immune system. Okay, gadolinium deposition disease antagonizes and disrupts the immune system. So here's your link. The sympathetic nervous system governs the immune system, and gadolinium deposition disease antagonizes and disrupts the immune system. So you want to be able to realize that there's a relationship between these 2 entities. The gadolinium is lighting up the immune system. The sympathetic nervous system is creating a dysfunctional immune system. And that's the link, that if you have gadolinium in your body and your body's susceptible to it, you're going to alter immune system function. If the sympathetics are dysfunctional as well, the real link is T cells as a form of immune cell. And CRPS causes a spike in T cells, and gadolinium has an affinity for T cells. So you're setting up this so-called perfect storm for horrible, horrible illness. Okay, so what causes the GDD type reaction in a susceptible patient? And again, this is a direct quote from Similka. I give him all the credit in the world. The exact knowledge and mechanism of any disease is not complete, but we know enough to figure out how things work. So based on the work of Similka et al., there are 2 full mechanisms that he thinks are causing this type of disease in people, and it helps to govern potential treatment. So number 1 is gadolinium substituting for calcium, and other cations in the body. What happens is normally the body relies on calcium, sodium, magnesium, manganese, different cations in the body create certain biochemical reactions that are responsible for health. And if you put the gadolinium into the body, and the gadolinium knocks that sodium or calcium or whatever other cation is on that chemical reaction off, and the gadolinium substitutes, now you have a biochemical reaction that's not sustainable for health and in the human body. So patients get sick and they start to show those symptoms. Okay, so that's one way gadolinium makes you ill, is a cation substitution, and it begins to explain symptoms. The other way that gadolinium can make patients ill is via the stimulation of cytokines. And gadolinium deposition disease is closely related to what are called AHRs. That's acute hypersensitivity response. It's basically where the immune system is overreactive and it stimulates too much immune system activity. And you've heard that term cytokine storm. That's what you hear about with the COVID virus and such. And here's in a nutshell what happens. The word cytokine means cell and movement. So cytokines are responsible for causing all the different types of immune cells in your body to do their jobs. But when you have gadolinium in your body, and or if you have CRPS, you have all these different types of immune cells that want to do something to help the body heal and or stay healthy. When you have this cytokine storm, they're all going off at the same time, and they're all doing it in an aberrant, dysfunctional fashion. Okay, so what happens is this. You have all of these symptoms that can hit you, either through substitution or through this immune system dysregulation. And according to Semelka and his research, all of these symptoms of GDD can be explained with these mechanisms. Some patients have the storage condition only, just like some people don't get CRPS and they don't develop it. And it basically comes down to host sensitivity. Not everybody who gets exposed to the COVID virus gets sick. Some people get mildly ill, some people get very ill, and unfortunately, a lot of people have passed away. It's host sensitive. Same thing with the gadolinium, same thing with the CRPS, which starts to make you think there's got to be a genetic component to this, and that's where the research is being focused with regard to at least gadolinium deposition disease, because the research of Semelka is getting down into studies at the level of the immune system and then to the genes that regulate. That's where a lot of the research is being focused to help people. Okay, how do you diagnose this disease? I said this is a disease. How do you diagnose it? And the answer is this. We already said not everybody who has the storage condition gets the disease. It's based on host selected immune system. It's based on how sensitive you are. It's based on patient medical history and such. Okay, but here we go. In order to be susceptible or suspect, rather, gadolinium deposition disease, you have to, of course, have had at least one GBCA in your lifetime. What happens too is patients become aware that every time they have another GBCA, their condition worsens with each subsequent GBCA injection. They get sicker, and they get sicker by showing more of those A symptoms. So there has to be a history and presentation of at least some of those GDD symptoms to suspect that there might be GDD with a history of having had at least one GBCA. It's not about how many you have. If you've had one, that might be enough to make you sick. So how do you go about diagnosing this? You have to undergo an IV chelation. And chelation is basically a term for putting another chemical into the body that's going to grab the gadolinium, hold on to it, and allow you to excrete it via urination. So if you look at what's up here, the best chelator available today is DDPA. And the only way to use it at this point properly for testing for GDD and treating is through IV chelation. Okay, people talk about EDTA. They talk about taking oral EDTA. EDTA, the order of attraction of DDPA to gadolinium is on an order of 1 to 300,000 times greater attraction to hold gadolinium compared to EDTA. So when people talk about my doctor used EDTA, gave me pills to take, maybe it helped a little bit, stuff like that. The way to do this properly is you must put the chelator into the body the same way the GBCA went in. So that's through IV. That's number one. Number two, you want to have it done at the same rate that a GBCA gets injected or was injected. It's done pretty standard. And then you want to have a chelator that's going to grab it and hold it to get it out of the body so you can pass it out. So remember, it's mainly stored in skin and bone. And those are the two places, especially skin, that's going to pull it from first. So here's what happens. How do you confirm that you have this disease? Maybe along with anything else you might have, but this is how you confirm the disease. When you begin your chelation, when the DDPA, when the chelator is injected, within minutes or so, you're going to get what's called a treatment-induced flare. Treatment means you're getting treatment, it's the chelation. And the flare means an exacerbation or an increase in the symptoms of this disease that you have. You have that wall of symptoms I told you about. You might get an increase in the symptoms you already have, or you might get another symptom. So you all of a sudden get a ramped up headache. You could all of a sudden get swelling. You could all of a sudden get itchy. You can have any type of symptom that you're going to get from the introduction of the chelator, and it occurs within minutes. That's a treatment-induced flare. that confirms the disease process. That's it. That's how simple it is to confirm this disease. Because what's going to happen is the chelator is pulling the gadolinium out of skin and bone and other organs that it sits in, and it's pulling it into the blood, and then it's going to hang on to it so that you can then pass it out via urination. Okay. The problem with EDTA is that it'll grab it, but it lets go. And now you just pass out the EDTA, and then the gadolinium just redistributes itself. I'm going to talk about redistribution versus re-equilibration when it comes to this type of treatment and such. But the way you confirm this is you chelate. If you get a flare, you have the disease. Continue treatment. What if you don't flare? Okay, then you don't have this disease. You might just have CRPS. You might have something else going on. Okay, but if you don't flare, good. It's one less thing to have to worry about. But if you do flare, you have to continue with chelation and treatment. It's not a one and done. I'll explain that to you. Okay, a positive flare response confirms you have the disease. It's a disease that can be quantified, it can be measured, it can be confirmed. Okay, now here's the other part that people don't talk about, and this is from all the research of Dr. Semelka and his research team, is that when you get that positive flare, you have to control the flare. And there are medications he uses to dampen the response of that flare. Because what can happen is, besides the fact that you can have a terribly painful episode from inducing the flare, which you do to confirm the disease, you want to contain it. And the reason for that is because if the body gets too overstimulated from the flare and from the gadolinium, you can actually create a situation where the patient becomes auto self-sustaining. And even if you got the gadolinium out of the body, they can still react as if they still have it in their body. And it becomes auto self-sustaining, meaning the body just keeps itself ill. So it's very important to do what he calls a frame protocol. You got to keep the flare under control. And it's the analogy I give is it's like you're teaching yourself how to put out a fire in your house. So you start the fire in the kitchen, but you don't want it to spread beyond the kitchen. So you have things in place to keep a fire from spreading, because if it spreads beyond the kitchen, it could take and envelope the whole house and everything is gone. So it's the same thing with the gadolinium. You want to frame or surround the symptoms and keep them from spreading beyond the flare that a patient's going to have. So you always have to use what's called a frame protocol, which is designed to keep the immune system response that confirms the disease from getting worse than it has to be, for the patient's sake immediately and then for the long term. Okay, how do you treat this? So here's what happens. Prior to the first chelation, we have patients do 24-hour urine capture to measure gadolinium in the blood that's being excreted. But look at that word, unprovoked, as a reference. Now here's the thing. People get fooled. Doctors get fooled. They see a level that's very, very low, very small. And the doctor says, hey, listen, that's a subclinical level. It's not significant. It's 0.23 micrograms, some amount. There's no reference for the amount of gadolinium that you might excrete in a 24-hour capture, because it doesn't mean anything. It only shows that you are retaining gadolinium and slowly releasing it, and it might be the reason that you're sick with this disease. You confirm the disease with the flare, but you don't get fooled, because an unprovoked amount is significant, but not the level. It doesn't matter how little it is, because you have to realize that most of it's being held in skin and bone and organs, and you have to provoke it with a chelator that'll grab it to pull it out. And here's what happens. The day before treatment, the day before the chelation, patients will start on immune dampening medications as prescribed at appropriate doses. This is how you begin to manage the flare that you're anticipating. Chelation is initiated with the calcium zinc DDPA. And if you flare, you have the disease, and it's critical to manage the flare. This is the part that nobody talks about. This is from all the research and work of Semelka and his team. This is a 2-day procedure. After the first chelation, you repeat the 24-hour urine test. And here's what happens is when you go in post-chelation analysis, that's where you're going to see the amount coming out of the body at a much greater amount than when they first came in. Because now you're pulling stuff out of those storage sites, which is mainly bone and skin, and that proves to you, number one, you flare, that you have the disease, and number two, that you're getting this stuff out. And that's where the DDPA comes in, because it's a much stronger chelator than any other chelator available today. That might change tomorrow, but right now, IV chelation DDPA, that's your best chelator. Okay, you have to manage the symptoms, and treatment for that is based on patient symptoms and medical history. Patients come in with very involved medical histories. Now, this is not a one and done. Depending on how many GBCAs patients have had, very often they come in with multiples. And unfortunately, that's because doctors keep missing a diagnosis. Maybe it's of CRPS or something else. They miss the fact that the gadolinium is making the patient sick, and they order another gadolinium to look to see why is this patient showing these symptoms. And patients actually get into this loop of getting multiple GBCAs, and it's the GBCA that's making them sick. So the more you've had, most likely the more sessions it takes to get this out of your body. You're not going to remove the gadolinium in its entirety. You can only, the thought process to remove enough to let the immune system take over if it can. And sometimes beyond that, the body still needs some medicinal support. And that's just based on person to person. There's no cookie cutter here. Okay, so it's done over multiple sessions. Now look at what it says here. You see how it says you do these sessions over 3 to 4 weeks time in between sessions. And there's a reason for that. What happens when you do the chelation, the patient's going to flare. That confirms the disease. They actually feel sicker from the flare, but you control it with the immune dampening protocol, with that frame protocol that Dr. Similka has devised. And what happens is they'll feel sick for a couple of days until they pass the chelator out with the gadolinium attached, and then usually there's a lull where they actually start to feel a little better, hopefully. And that can last for a couple of days to maybe a week or so, and all of a sudden they start to feel sick again. And what's happening is what's called La Chatelier's principle of equilibration. And what that is that if most of that gadolinium came out of skin, as a for instance, because that's where it's mainly stored, the body says, wait a minute, I need a certain percentage of gadolinium back in the skin as a dominant place to store. And now you got more in other parts of the body. So the body says, give me back some into the skin. So it starts to pull gadolinium out of other places to put it back into the skin where it wants to predominantly store it. And when that gadolinium hits the blood, you start to get sick again. That's La Chatelier's principle of equilibration. That's a fancy term for the body redistributing the gadolinium the way it wants to be for storage purposes. Okay, now the good news is that when you do the chelation properly with DDPA, that redistribution principle occurs, but you've also lowered the amount in the body. Okay, so when you use something like EDTA, instead of getting a re-equilibration after elimination, you actually get just a redistribution. The EDTA will grab it, pull it into solution. The EDTA lets go. You urinate out the EDTA, and now the gadolinium just redistributes itself. So you show symptoms, but you don't get a lowering of the gadolinium out of your body because the EDTA is not strong enough to hold it. So DDPA is your best chelator, especially compared to the other ones out there right now for IV chelation treatment. And oral forms, I don't think it's even in the conversation. State of the art today, might change tomorrow, is chelate with calcium and zinc DDPA done over 2 days. Okay. The poor chelators are going to lead to redistribution without elimination. The strong chelators, you get a re-equilibration of what's left. Then the idea is that you keep treating until the patient's body can take over and then begin to manage itself. And that could be 3 treatments, 5 treatments, 10 treatments. We don't know. It's based on patient response to treatment. And that's also governed by, you can retest the output, and hopefully you see, let's say after 5 treatments, as a for instance, that the level coming out post chelation by the 5th chelation is lower than the first one. So you're showing that the amount left in the body is coming down, but you don't know where you'll hit your threshold until you get to it and patients improve with their symptoms. That's what you're looking for. Okay, so are you abating or are you curing? Well, it's up to what happens with the patient. Abatement means you're putting the symptoms to sleep. Cure means it's done. And what's good about gadolinium deposition disease is you can treat it to the point, if the host is able to do so, to the point of cure. You can have multiple diseases, and you can have GDD, but the GDD can be treated. You treat it by getting it out of your body. You went in through an IV, get it out through an IV, and then monitor symptoms, control the flare, and measure what's coming out. By measuring what comes out from chelation, it does not tell you how much is left. You measure patient response to treatment. You measure, do they improve? Because as they improve and you sustain that improvement, that's showing you that the body's starting to take over if it can. And if it can't, there are other medications that are recommended. That's Dr. Semelka's area of expertise. I'm here to give you the most basics. So, in a nutshell, CRPS and gadolinium, are they two independent parallel diseases with a comorbidity? Can they coexist independent of each other? Absolutely. You can have one or the other or both. Does gadolinium deposition disease cause CRPS? Yeah, the link is the toxic effect and the stress to the sympathetic nervous system can cause a CRPS-like event, and also the immune system flare that gets created by the gadolinium. What we know from the research of Semelka is he's measured at the level of cytokines, through serum blood studies, that there are certain cytokines that are ramped up from gadolinium toxicity. So pre and post chelation, not only do you measure output via urinalysis, but you measure pre and post serum studies, and you can see what cytokines were active or what levels they were, and then you go through the chelation, and you watch which ones get ramped up, and all of a sudden you have a way of measuring and confirming that this is a disease, because look at the effect on the immune system that's happening. That's the research that's going on here and now, and it's published. It's not hearsay, it's not opinion, it's not anecdotal, it's fact. Serum level studies confirming that gadolinium ramps up various components to the immune system, and some of those immune system cells that are ramped up are the same ones that are involved with CRPS. So there is a link. Okay, can CRPS cause GDD? Yeah, patients come in and they've had CRPS for a while and it gets missed. They miss that Budapest criteria. They miss the symptoms that patients are showing. So they go to one doctor, to another doctor, they go to all different specialties, and doctors start ordering imaging because they're trying to figure out, why do you have this pain? Why do you have this swelling? Why are you having a problem with your heart? Why are you having a problem, with brain and concentration? So here comes imaging. Well, the imaging didn't show anything, so maybe we should do a contrast study. And here comes the contrast study. And if the contrast doesn't show anything, they look for a contrast study maybe of another part of the body. Here comes another contrast study. And all of a sudden, you've got the potential for a GDD event on top of the CRPS. So each of these can exist independent. One can cause the other. Okay, so here's my take home for this. As part of a medical history, and this is for, for anybody listening as well as doctors, as part of a medical history, if I suspect CRPS, I also ask if they've had MRIs and CTs with contrast, because that might be a potential trigger. It might be that it's GDD and not even the CRPS, because the overlap of symptoms is almost identical. And if they've had IV with contrast, and I can ask them, do you remember not feeling well? Do you remember what happened to you? And you ask those kinds of questions. It's a clinical assessment. And I look for symptoms of GDD, which pretty much overlap with the CRPS, but I also look for signs that they're not abating, that they're not responding to treatment. But at the get-go, I want to know, have you ever had any GPCAs or not? If they have, I'm already thinking that there's a potential GDD event going on here. And I can't do it as a dentist, but I'll call up their primary care provider and say, listen, I want to get a heavy metal test for gadolinium toxicity, and I'll explain to them, and hopefully they listen. That my experience has been they will and they do. It's an easy test to order, nothing to do with the doctor, he just has to order it. If the urine capture test is positive for GDD, they at least have the storage condition. And in essence, if you have had a GBCA, you're going to have GSC. Doesn't mean you're going to get the disease. There's always the potential that something could trigger it. But you might have CRPS or just GDD, or you might have both of them potentiating and really hitting you hard. I tell people, if there's a level of gadolinium in your body, you're showing signs of GDD, I would recommend them for chelation. It can only help. The worst thing that happens is you make the time and money investment in the chelation event done properly, and if you don't flare, good. It's one less thing to worry about. It's off the table, and now we can just focus on, if they satisfy Budapest criteria, that is a sympathetic event only, and then I can just focus on that and look for other triggers. Okay, I put this up here and I'll send it to Trevor. This is Dr. Semelka's place where he practices out of to do his chelation. You can just Google his name and you'll see it. He is the true expert. This is his disease he named. He's a radiologist who came to realize that there's a problem with this gadolinium, and his research team is showing that this is a disease, cannot be disputed or refuted. People can say whatever they want. This is a definable, confirmable disease. He is the expert. And when I have patients that I suspect this disease in, I send them to him. It's the only place I would trust, because it's not just about the chelation, it's about controlling the flare. You can confirm the flare, but you got to control it. And that's, if I need it, if a family member needed it, we're going to see him. That's the best I could tell you. And please understand, I don't get anything for saying this. There's no money involved here. This is because he is the true world authority. It's his disease, his research, he named it. With that said, we formed, and I'm proud to say I'm a member of this board, GADTRAC. It's a non-profit. There's no money involved for the board members. Healthcare charitable organization established to diagnose, treat, research, and assist patients who were poisoned by gadolinium and heavy metals. And we're looking to raise money for the research to treat, and the biggest research is going at the level of DNA in the genes, and also to get money for patients who truly can't afford the treatment but need it. So we just started that. And again, I can post this type of stuff with Trevor, who was nice enough to put this together. Donations can be made soon. They'll be on the GADTRAC website, a PayPal way to donate. Again, this money goes for research and to help patients who otherwise could not afford it. I give all the credit in the world. This GADTRAC board is doctors and non-doctors alike, with all have areas of specialties and commitments to help people. I want to thank you. That's the end of this presentation. I'll click out of this. Here's my email. We have plenty of time for questions, no limitation. This is my website. If you have a question that I don't answer tonight, you can email me. I would rather you email me your name and phone number, because I'd much rather talk to somebody than have a conversation via writing and texting, because oftentimes I have my own pertinent questions.
My question is, I know I've spoke a lot to you and everything, and we've got this organized, and great presentation, by the way. But I wanted to ask you if you knew anything about when I was getting ketamine treatments for this last big flare that I had that was caused by ice. They added MDA. What do you know anything about the MDA? If you do, can you share with us if it's beneficial or a gag?
Wait, I'm sorry. What was the question, Trevor? I missed that.
MDA. Can you not hear me?
I hear you. Go ahead.
Okay. When I had my IV ketamine infusion 2 times ago, when I had my torso flare, they added MDA. Have you heard of that before?
What is it? Tell me.
Well, I would have to. They added it. It's supposed to restore your cells, and I can't remember what it stands for. I would have to click out, but we could talk a little bit about it later. But they added magnesium, and I felt that helped a bit. What's your opinion on additional magnesium? I mean, I take it by pill form also.
What are you trying to treat? The CRPS?
Yeah. Yes.
You know, truly, I don't know, because I'll tell you this: if it's helping you, then do it. That's the best advice I can give you, because I don't claim to know everything about this. I just know what I know, and I know what's been successful for me with containing and diagnosing sympathetic dysregulation, at least to the carotid dermatome, head, neck, and face, and I often catch upper body. It's just a matter of how involved the patient's damage is, and how injured they are, and how sick they are. People come in with multiple comorbidities that makes it very difficult to treat. So I'm looking for what things are keeping somebody lit up, what things are making somebody ill, and things like that. Okay. So if it's Trevor, if it's helping you, I'm happy. That's the best I can tell you.
I don't know, because there's been another regime added to my medication, morphine, so I can't, they were added at different times, so I can't differentiate, so I'm gonna seek your I'm gonna seek your diagnostics soon, but Anyway, I'm finished. Somebody else can talk now.
Who else?
I had another one. Can you hear me?
Yes, go ahead. Hi, Allison.
Okay. These were about some of the, I don't know if it was just about the sympathetic nervous system, how you said it can cause, other parts of your body to do stuff that I never really had associated with the CRPS. So like my right eye waters all the time, and I never had associated that could be from this. I just thought it was my right eye watering. So that you're saying could be part of a malfunction of the sympathetic nervous system.
Yeah, absolutely. So have you ever had any of the GBCAs that I talked about? Any contrast studies done?
I've had a couple MRIs, but I don't think I got gadolinium. I don't know if they gave it to me for the brain one I had, but I would have to check back to see if I had contrast, because I
Right.
know I've had contrast for CTs, but I don't know that I've had gadolinium.
Right. Okay. So let's assume you didn't, if you're not sure, because usually you remember a shot in the arm and things like that during the procedure. But the leaking eye, that's basically a pseudomotor event. It's fluid. And that's why I said fluid. One eye. People come with fluid coming out of their ear. At least you can understand your eye tearing or your nose leaking. But it's a unilateral event. And you try to investigate it and see what's causing it, but usually they'll start looking on imaging for blockages and things like that. And you want to make sure there's nothing else going on. You always want to rule out, go through your rule out. When people come to me, I don't say, hey, it's CRPS, you got this, you got that. I say, make sure have you been to the ENT? Have you been to the ophthalmologist? If they say, yeah, he couldn't find anything, this guy couldn't find anything, and they can't find it. Okay, now it's almost, okay, now let's talk about some other symptoms. I start asking about things that I'll ask about to the hands, to the feet, to the rest of the body. Do you ever have trouble sleeping? You ever feel sick? And things like that. And I start to get positive answers. That's what starts to pump me towards sympathetic. So what do you do about it? I don't know. I have to.
Yeah, I mean, it's not super bothersome. It's one of those things. I mean, when you have severe pain, you're leaking eyes, nothing, But that and the hair loss, I know a lot of the other women in our group, I didn't know if the hair loss from CRPS had to be on your affected limb, because I have lost in the last year probably half of my volume of my hair. And I didn't know if it came from the CRPS or if it came from our medications.
Hair loss, ectodermal tissue, patients have nails slough, toenails, fingernails, hair loss, hair thinning, those kinds of things occur. And the leaky, let's look at it this way, a leaky eye, hair loss, that's what I talked about, that fourth category of dystonia and trophic changes. Trophic is skin and nails. So you're right, you're describing sympathetic dysregulation. How does it happen? I can't explain it. I can just tell you I know it. That's if you answer positive to that and you got the fluid, the pseudomotor type thing, you're and the non-resolving pain, you're lit up. You're showing signs and symptoms of the CRPS. The question is, what are you doing to try and control it? Such.
Yeah.
What was your treatment? Did you have trauma?
I was originally diagnosed with Parsonage-Turner syndrome. I don't know if you're familiar with that.
No.
Another name is brachial neuritis.
Brachial neuritis. Okay. Stop saying
Yeah, and then they felt that it had morphed into, so then they did a surgery for that. And then they felt like it morphed into CRPS going down my arm. So for the last 2 years, I've had several different kinds of like nerve root injections. I go to PT weekly for like deep tissue massages. I get trigger point injections every 3 weeks.
Are those
medicines.
Helping?
The trigger points do help because my like traps and down my scapula constantly like get spasmed up. I have a lot of muscle atrophy in my deltoid. It like completely like dented in.
See, so can you guys see me better now? Because what's interesting, instead of a trigger point into the muscle, knowing you have CRPS and knowing that you have those spasms in the trapezius. So first question always is, have you had your cervical spine, I'm talking C1, to C3, C4 looked at, and properly evaluated on scans, either CT or MRI. And then number 2, these blocks I'm telling you about, so you all know here, obviously spinal cord's in the back. I'm going to turn to the side to show you, because the nerve blocks I'm talking about doing every day, they're peripheral. So they're can you all see? Here's the sternocleidomastoid muscle, the big neck turning muscle. Here's the angle of my jaw. It just basically draw a straight line over the sternocleidomastoid muscle. Here it is. See, I'm grabbing it, and then the needle injection. It's not deep. It's not like a flu shot where you're injecting deep. It's under the skin and over the muscle, because that nerve comes out from the base of your skull, comes out deep, exits superficial. It's called the superficial cervical plexus, and it's coming out about halfway the length of the SCM, and it gives off its branches. And one of them is the greater auricular. Auricle means towards ear, so it comes up straight up like this. So I draw a line across the angle of the mandible across the sternocleidomastoid muscle, and then I just come in under the skin at one side of the muscle, come under the skin, over the muscle, and right to the other side. I'm pincing it so I can feel it. And then I start to inject. It's a slow injection. It's not like a flu shot where you go in and just jam it in there. It's very slow because you're going under the skin and then just backing the needle out as it works, as you inject, and then you finish and you wait. So it'd be interesting in your case if you can find somebody to block you and see if they can do a sympathetic block and see if it reaches all of this. Because rather than keep sticking you in the trap muscle just to break up those spasms, it'd be interesting to block the sympathetics that supply those areas. So one is the greater auricular, the other is the lesser occipital. That's the other branch that comes off of here. These are loaded with sympathetic nerves. And see if it hits it. And then you have the greater occipital, not as highly innervated because that's more what's called dorsal. Sympathetics are more ventral. But I catch greater, lesser, and greater auricular, and amazing when you see people, their neck loosens up. I'm not touching the trap, but everything lets go. And it shows it's a sympathetic event. Now, what if it doesn't? Okay, then it's not sympathetic maintained. Okay, now do your trigger points and stuff. And a lot of that atrophy is because the muscle is not getting stimulated. It's not getting stimulated because the sympathetics might be blocking it. So it's just something else to consider.
I mean, wouldn't you think most pain management doctors would do those?
Ask them. They don't. I'll bet you some of it's because it's not covered by insurance. I don't have any limitation on me. I don't let an insurance company tell me what I'm going to do or not do for a patient who needs treatment. I just go in and I do. And the way I treat my patients. Pardon me? You're
in New York though, right?
Long Island, yeah. I mean, I just have a flat fee for what I do, and it's a flat fee. It's basically, I say it's for a year, but it's basically lifetime. Because you know what happens? You get the crips under control, you get it into abatement, and if they flare, it's covered. You know, forget insurance. You give me a fee up front, and it covers you for the next year and then beyond. It's like Buzz Lightyear, infinity and beyond, because it's not that often that I have to do it once you get them under control. And then, okay, so what are your triggers? Is there what we're going to get that? We'll get that treated. If there's a Georgian issue, get it treated. If you have some other injuries, some issues that are still keeping you lit up, we get it treated. That's the way you do it. Okay, you can unmute so I can hear you. Don't worry about the door.
I think that's about it. I think those were most of the questions I had.
Okay, I hope that helped you.
All right, thank you. I appreciate it.
Thank you. All right.
Hey, can you hear me?
Yes, go ahead.
Okay. I was going to talk to you a little bit about, are you going to share a link of this recorded presentation? Yes. Because there was many people that, you know, in different time zones and areas of the world and stuff.
Yeah, this is being recorded, and what we can do is I'll send you the recording or the link to it. I'll create the link, and then I'll send it to you, and you can post it. And then people who want to watch this and listen again are welcome to do so at their leisure. I told you we do that. No problem.
Yeah, okay? I just wanted everyone else to hear that.
Right. The other thing I thought I would do for you for the site that you created, Trev, is I'll create like a bunch of handouts, like the diet, the smokers information, the Budapest criteria, the or anything I think would help people who either listened or maybe want to listen and hear it can also get the readable material that I'll send to you. You can post it so they can, and it's made PDF so you can just download it. Click on it and download it. That's the best way to do it. Let people have this information so they can take it to their doctors. Here's the Budapest criteria. Here's the symptoms for GDD. Doctors, listen to your patients. That's the bottom line. And learn and then apply the knowledge and get to treatment. You know, and I'll tell anybody listening that if you want me to, I'll speak to your doctor. I have no problem with that at all. The goal is to get people proper care, proper help as we can.
Well, I know that I truly appreciate every time you talk to me. You're a brilliant man, and
Oh,
I've learned so much from you. And
thank you.
I find you're a true humanitarian, and I really appreciate what you're trying to do. And I started my website because a lot of the other websites, they wouldn't let people they would let people post pictures, but it had to be in comments. It couldn't be as a regular post. And so I wanted to create a group that, let doctors in. And I, you know, I don't, I don't know if you joined in there yet or not, but I think we discussed this. She was going to wait until afterwards,
Right.
but anyway, I want people to learn new stuff. And, all we have to do is sit on our butts, pardon my language, and Google stuff, and it gets really freaking depressing. We need to hear the stuff that is uplifting and that there is hope. And I think you're a piece of that.
No, thank you very much. And it's a point well taken that there's way too much information out there. There's too much anecdotal, too much opinion. That's why tonight I just tried to give everybody objective information. Budapest criteria. You don't need bone scans. You don't need thermographic studies. Budapest criteria, confirm, treat. Because the more time you waste trying to figure it out, the more time's been wasted to get in there and start to treat symptoms. Keep this thing under control. Get the leashes on the dog. That's the way I tell people. And first get them to understand the nature of this disease and what it is. I spend a tremendous amount of time either with patients in person or on the phone, as you've seen, to explain to them, to let them see, hear, understand what's going on, and then treat. Same thing with the GDD. If you got it, get it out of your body. That's the simplest cure there is. Get it out of your body. Can't make it any simpler than that. CRPS a little trickier because it's involving a part of your human body versus a chemical you can just get out of your body. But there's no doubt that they can potentiate themselves. So I appreciate your comments. Very nice. Thank you. Try my best to help.
Yes, you're very welcome. I can't wait till I'm able to get up there and see you. And I'm interested in that diagnostic stuff. I've already did the gadolinium test, but me and you both feel we should redo those again. And I think I agree on that too, because I've had too many of those tests.
All right.
Well, thank you, Doc.
Yeah,
Okay.
thank you.
All right. I hope that helped anybody. You can reach me via my emails. If you have a question, want to talk, let me hear from you. I'll be happy to help anybody any way I can. Just the goal is to get people better and not have to suffer if you don't have to suffer. Doesn't mean you can cure it all, but that doesn't mean you can't get things under control. And it's all about getting that quality of life, no matter how you do it.